So if Kathy has just talked about the favorable prognosis hormone-sensitive tumors, my task is to speak about the optimal chemotherapy regimen for the other half of the coin, or the other side of the teeter-totter, or if you've read Dan's editorial, the other side of that figure, to talk about whether or not there is an optimal adjuvant treatment. And I will tell you that the answer is yes, but I will not divulge that until the end of my remarks. So what are the challenges in defining the optimal therapy for triple-negative breast cancer? We've heard already at this meeting about the intrinsic heterogeneity within triple-negative breast cancer, and we will accept that as given, and it's obvious that there are the lack of targeted therapies. Clinically, this is a disease associated with younger age and with hereditary cancer syndromes, and because of the higher innate risk, we have a lower stage of threshold for treatment, usually initiating therapy for low-risk small tumors. The question is typically not whether or not we should give chemotherapy, but which chemotherapy and how much. And the trade-offs still include consideration of both the short and long-term side effects of chemotherapy, but this has to be balanced more against the intrinsic risk of the tumor, the lack of other treatment options, and the treatment needs. Now, in reviewing this literature, it's worth noting some analytical deficiencies. There are very few trials specifically arranged for triple-negative breast cancer. There are subset limitations that are familiar extensively to this audience, the post-hoc nature of them and the lack of power and events. And finally, many major trials, and including the overview, are confounded by a lack of the crossed analysis of the 2x2 analysis of ER status and HER2 status. So despite those, let me review briefly with you the standard chemotherapy approaches and then talk about efforts that have been made to move the field forward. The overview has garnered much attention already at this meeting. I will not belabor the discussion of anthracyclines versus CMF or taxane versus not, except to say that in hormone receptor negative tumors, there was significant benefit for each of these, particularly, I would say, in the taxane versus not group. If you look at important trials over the past decade, there are studies that have looked at the schedule of taxanes from the ECOG 1199 trial that argued reasonably persuasively, I believe, that the weekly paclitaxel therapy was superior to other kinds of taxane-based treatment. In NSABP B30, published about 2 years ago now, they compared sequential therapy versus concurrent therapy with 4 cycles of TAC or the AT regimen. There was a benefit for the sequential therapy of AC followed by docetaxel in this study. And if you look at subsets, again, in the ER negative group, this benefit or trend towards benefit was again apparent, favoring the sequential treatment arms. A single study has compared AC versus the TC regimen, which is widely used in the US. They have not done a 2x2 analysis, but there was an aggregated benefit for TC, and in all subgroups defined by ER or HER2 status, those benefits were again apparent. Now, many investigators have reported on what I would call the 2x2 analysis, and these findings have consistently demonstrated benefit for more modern approaches to treatment, particularly in triple-negative breast cancer. We have here the data from Dan Hayes in the CLGB 9344, looking at AC with or without paclitaxel, showing clear benefit for the taxane in the triple-negative group. Here's the BCIRG study, TAC versus FAC, again, clear benefit in the triple-negative group. Here's the GuyCam 9906 study, FEC versus FEC with paclitaxel, and again, clear benefit in the triple-negative group for the addition of taxane-based therapy. More recently, efforts to look at the scheduling of AC followed by paclitaxel have employed the intrinsic subtype classifier. These data were from Minetta Liu and colleagues at the San Antonio meeting. They did not find a clear signal that you could particularly identify which group did or didn't benefit, but if you look at those who had the basal-like breast cancers, there was a trend most significant or most positive favoring the dose-dense approach. So, if taxanes are really critical in triple-negative breast cancer, what can we say about some of our other agents? And that requires going back further in the literature. In NSABP B15, looking at AC versus CMF for tamoxifen non-responsive breast cancers defined as those lacking PR status, subset analyses have been done principally to prove the benefit of anthracyclines in HER2-positive disease. But on the distaff side, you'll see that there's no difference in comparing the outcomes for the HER2-negative tamoxifen non-responsive regimens. In a pooled analysis from multiple NSABP trials looking at node-negative, ER-negative breast cancer, again with a caveat that we do not have HER2 status, you see what looks like sequential stepwise improvement in outcome when you first add chemotherapy compared to baseline using MF and then using CMF. But when you compare AC versus CMF, actually the results are exactly the same. And a meta-analysis, which was used to justify the value of anthracyclines in HER2-positive disease, at the same time showed a lack of benefit for anthracyclines in the aggregated experience of HER2-negative breast cancer. Finally, as Kathy already alluded to, we have the intrinsic subtype analysis from the MA5 trial comparing CEF versus CMF. And in the basal-like subgroup, there was no strong suggestion of benefit from the anthracycline-based arm. So I would say that standard chemotherapy agents are effective, particularly in triple-negative breast cancer, that enhancements to adjuvant chemotherapy, including the addition of taxanes, sequential therapy, and novel scheduling are valuable, particularly in triple-negative breast cancer, and that while anthracyclines are a standard component of our modern adjuvant regimens, there are persistent questions about their importance, including in that subset of triple-negative breast cancer. So have we made any progress with anything else? Recent studies have looked at the inclusion of capecitabine as an active agent in adjuvant regimens. This study from the U.S. Oncology Group was reported at the ASCO meeting in 2011. It compared AC followed by a taxane with AC followed by taxane and capecitabine and showed no significant benefit overall, though there was a trend as shown in the analysis at the bottom suggesting perhaps more benefit in the triple-negative group. We also had the FIN-XX trial, which looked at taxane with or without capecitabine followed by CEF. And if you focus on the triple-negative breast cancers here, there is the suggestion of benefit for the addition of capecitabine. An enterprising investigator quickly pulled together a meta-analysis which has suggested disease-free survival in the cohort of triple-negative breast cancer patients given capecitabine from these two pooled studies. But I think most of us would agree that the data from two essentially negative overall studies require further clarification. NSABP B38 looked at whether or not the addition of gemcitabine might improve outcomes. It did not, nor did it specifically in the subgroup of ER-negative breast cancer patients. There has been much interest in platinum-based chemotherapy, both here at this meeting and in clinical discussions. And much of this has been driven by the observation of phenomenally high complete rates of pathologic response in women who had hereditary breast cancers receiving platinum-based chemotherapy. In a recent review in a small series of patients who had BRCA1 mutations, the vast majority of which were triple-negative, you'll note the gaudy 83% response rate to upfront use of platinum-based chemotherapy. However, a variety of small, open-label experiences looking at triple-negative breast cancers in a non-selected fashion for hereditary mutations has shown a reasonably consistent 15 to 20% rate of complete pathologic response, again with very small numbers of patients, but certainly not enough to adopt as a standard approach and raising questions as to whether there is truly a novel signal here in unselected triple-negative breast cancer. We're going to hear later on today about novel neoadjuvant approaches. However, in recent studies that were published in the New England Journal of Medicine, two groups independently looked at whether or not adding bevacizumab to chemotherapy would improve outcomes in the neoadjuvant setting. The German breast group and the NSABP both reported outcomes for triple-negative patients as a subgroup of their studies. In the German group, there was a statistically significant improvement in PCR. A more modest benefit was seen in the NSABP experience. However, this has not apparently translated into a benefit in the adjuvant setting. Data from David Cameron, presented at San Antonio in 2012, showed the Beatrice study result, a trial of 4 to 8 cycles of chemotherapy given with or without bevacizumab, showing no difference in disease-free or in overall survival. This highlights one of the practical dilemmas right now in neoadjuvant therapy, which is what would it take to change the neoadjuvant response to translate to an improvement in event-free survival. And Pat Cortazar from the US FDA spoke to this at the San Antonio meeting. She noted the familiar observation that triple-negative breast cancers that have a complete pathologic response tend to do better than those that do not, and made the effort to model what it would take in the way of a PCR improvement to translate to a difference in event-free survival in the various reports. Ideally, this would be a perfect model where every incremental improvement in PCR this way translated to a benefit in terms of the event-free survival hazard ratio. However, when looking at all the subgroups of breast cancer, including the triple-negative group, there was in fact no relationship between the magnitude of the PCR odds ratio and the improvement in the hazard ratio. I think this raises some very fundamental questions about how valuable PCR may be in actually developing therapies, but I'll have more to say about that in a moment. So what can we say about what people are doing in clinic and guideline recommendations? These are data highlighting the risks of small sub-centimeter tumors. This particular experience happens to be from the IEO in Milan, though any one of a number of different studies could have been pulled to make the same point. It emphasizes the fact that for even small node-negative, triple-negative breast cancers, there can be reasonably significant risk. We have again generated much of these data to justify the use of trastuzumab in small sub-centimeter cancers, but if you look at similar outcomes for patients who had triple-negative breast cancer, you'll notice that in the T1b lesions, the risks are about the same as the HER2-positive hormone receptor-negative group. And actually, there is still 15 to 20% risk of recurrence in that group of women who had hormone receptor-negative HER2-negative tumors that were either T1 mic or T1a, that is 5 millimeters or less. And it's these kinds of risks that have prompted many people to treat very small triple-negative breast cancers. In fact, a recent analysis of NCCN practice patterns polled by one of our trainees, Inez Luis, which has been submitted as an abstract, looked at the patterns of practice in NCCN institutions for small node-negative breast cancers broken out by their subtype. And what you can see here is that in the triple-negative tumors, our threshold for treatment is very low, as it also is in the HER2-driven cancers. At least half of the patients who have T1a node-negative cancers are receiving adjuvant chemotherapy as of 2009, and over 2/3 of those with T1b lesions are receiving chemotherapy in our NCCN centers. Indeed, NCCN guidelines recommend consideration of adjuvant chemotherapy for T1b tumors and for node-positive breast cancers if they are triple-negative, confirming the very low threshold for recommending initiation of treatment in this particular breast cancer subtype. They identify as well preferred regimens, including the dose-dense AC followed by paclitaxel regimen or the regimen of docetaxel plus cyclophosphamide, and acknowledge a variety of other regimens that could be effectively used. At St. Gallen in 2011, we endorsed the use of cytotoxics as treatment for triple-negative breast cancer, and I think one of our questions for tomorrow may be at what threshold and what regimen. So let me offer a couple of summary remarks. First, because of the lack of targeted therapy, the intrinsic recurrence risk, and the efficacy of chemotherapy, our thresholds for adjuvant chemotherapy treatment for triple-negative breast cancer are quite low, at approximately 0.5 centimeter in node-negative cancers, and this is despite the familiar side effects, both near-term and long-term, of chemotherapy treatment. The data to me suggests that the optimal regimen should, for the moment, continue to include cyclophosphamide, taxanes, and anthracyclines, and I would score the data as being either insufficient or flatly negative at the moment for the additional treatments using capecitabine, gemcitabine, platinum-based chemotherapy, or bevacizumab. So I think the standard of care, based on direct comparisons, a variety of subset analyses, and a personal consideration of toxicity and tolerability, suggests that sequential anthracycline, cyclophosphamide, and taxane-based therapy remains the optimal regimen. And I think one could rather convincingly argue that dose-dense AC followed by paclitaxel given either on a weekly schedule or a dose-dense schedule is the preferred regimen for treatment of patients who have triple-negative breast cancer. For those who wish to avoid anthracycline exposure for any number of reasons, the taxane-based TC regimen, I think, is supported by a rather robust set of data in favor of taxane-based chemotherapy, though for those who prefer either to avoid taxanes or avoid anthracyclines and taxanes, AC and its variants and CMF remain options. The neoadjuvant regimens, it goes without saying, but will be said, should be the same as those as the adjuvant regimen setting, regardless of treatment response, PCR, or lack thereof. Finally, there are some key opportunities and priorities for research moving forward. I think the event rates in triple-negative breast cancer should enable us to move forward with familiar adjuvant trial designs, though we should have studies designed and powered specifically to look at outcomes in triple-negative breast cancer. The role of anthracyclines, as being studied in NSABP B49, remains an important one in the modern era, and hopefully we can answer that soon. Again, molecular and genomic correlatives to identify subgroups of subgroups will be critical. And finally, I think we need to really think about this neoadjuvant program the FDA has proffered as an accelerated approval strategy, clearly for potent, novel agents studied in an add-on design with adequate sample size and planned long-term follow-up. This is an unmet need and is an opportunity for innovation, but the relationship of the change in complete pathologic response that will need to be seen and the change in event-free survival remains unclear. Thank you very much.